Hi class, welcome back. This is our lecture on examining the nervous system. We are going to talk about a couple different aspects of the nervous system today, including the mental status, speech, and language, which we've already talked about in, I think, week 1 or 2 when we talked about the general survey. So today we're going to focus on the cranial nerves, the motor system, sensory system, and then reflexes. Alright, so let's go back here. So remember just a little bit of background. The brain is divided into 3 main components. This cerebrum, which includes the frontal, parietal, temporal, and occipital lobes. We'll go over those very briefly. And then the cerebellum, and then the brainstem, which includes a couple different areas. The diencephalon, the midbrain, pons, medulla, all those things. The frontal lobe and the parietal lobe are responsible for different aspects. Same with the occipital and the temporal. They're all kind of responsible for different functions, just different sensory or parts of our emotions. So the parietal lobe tends to be our sensory functions like taste, touch, pain, temperature, right versus left discrimination. It also is associated with reading. So if there's a lesion or a deficit in this area, it can manifest with problems in reading, math, neglect, sensory deficits. The frontal lobe tends to be more our personality and emotion, our judgment, our intellect. So patients sometimes have a frontal lobe dementia, tend to have much different emotional responses and personality than what they used to when they were younger. So they're, a lot of times if a man with a frontal lobe dementia, frontotemporal lobe dementia comes in, and the wife will say, he was never like this. He was never this mean, or he was never. Sometimes it's sexual behaviors. They say kind of really crazy sexual things, and the wife is just mortified. She says he would never in a million years say this, but the lesions or the deficits affect this area and cause changes in emotion, personality, and things like that. The occipital lobe tends to be primarily the sensation or the sensory function tends to be tied with vision. So when you hit your head, in the occipital area, sometimes you see stars and go black, but that's where our vision centers kind of are. And then the temporal lobe tends to be with our language, smelling, hearing things. So if there's lesions in these areas or deficits in these areas, lesions in these areas can show up as deficits in these sort of functions. The cerebellum is the area of the brain that's most often associated with coordination, with muscle coordination, with balance, with equilibrium, and this is obviously then makes sense that this is the area of the brain that is affected by alcohol consumption. So this makes sense when you look at how problems in this area manifest: ataxia, balance problems, eye-hand coordination movements. And this is why, as some of you might know, cops put you through a little mini neurologic assessment when they're performing sobriety tests. So we're going to show you this YouTube if I can get it to work. And this works when these are face-to-face visits, but I'll try to see if I can get this to work. Hold on just a sec.
Doing?
Well, I'm great. I'm doing okay. How are you?
Okay. I'm not so good because you were weaving all over the road there.
Well, can
Sir?
we get one thing straight? I have not been drinking.
Okay.
And
right hand to the nose.
yes.
With the left hand.
All right.
And back out. I need you to recite the alphabet from Z to A backwards as fast as you can.
From
Can you
Z
do
to
that
A?
for me? Yeah.
Sure.
Backwards.
Z, Y, X, W, V, U, T, S, R, Q, P, O, N, M, L, K, J, I, H, G, F, E, D, C, B, A.
All right. Remarkable. I've actually never seen anybody do that.
Oh, my bladder's full.
I'm not worried about your bladder right now.
Sure.
Okay.
10.
All right. All right. Well, you got pretty good balance.
Thank you.
I want you to step, bump, bump, step, bump, bump. 5, 6, 7, 8. Step, bump, bump, step, bump, bump. Pas de bourrée, kickball change, step, clap.
Okay.
5, 6, 7, 8.
All right. You know what would be good is if you hip kicked and then you kind of did that and then a barrel turn and then ha. You know?
That was good.
That would be.
That was really good. You a dancer?
No. I'm just drunk.
Up against the vehicle right now, sir.
So that's obviously not real. This is a Reno 911 skit, but it's hilarious, and I wanted to share that. Real sobriety tests often include some of those elements, walking heel to toe, heel to shin, parts of the rapid alternating coordinating movement test, which we'll go over today. So police officers often put people through these mini mental status exams to test their cerebellar function and see if they're impaired from alcohol. Okay, so again, we're breaking it down into these 5 sections: mental status, cranial nerves, motor system, sensory, and reflexes. The most common that we're going to be tested to really worry about or highlight is the cranial nerves. Level of consciousness, we already talked about this when we talked about the general survey. The patient really should be alert, oriented, fully responsive when you speak to them in a normal speaking voice. Lethargic patients will appear drowsy but respond appropriately, but then they tend to fall back asleep. You'll have to use a loud speaking voice in order to usually initially wake them. If you have to shake the patient in order to wake them, they may be more obtunded. They tend to respond very slowly. They seem disinterested in their environment. And then stupor, generally they're arousable to pain, but there's no verbal responses, they're very slow. And then coma patients are unarousable. Cranial nerves, there's 12 of them: olfactory, optic, ocular, motor, trochlear, trigeminal, abducens, facial, acoustic, glossopharyngeal, vagus, accessory, and hypoglossal. How are you going to remember all of those? Well, luckily there's little mnemonics that you can use to help remember them. One of them is O, to touch and feel a great vein, heaven. Another one, once one takes the anatomy final, a good vacation seems heavenly. There's a couple dirty ones, which I'm not going to share with you, but you probably remember them from nursing school. But these are the ones that seemed appropriate to share. You'll notice here that cranial nerve 11 in this mnemonic is A, and cranial nerve 11 on this mnemonic is S. And that's because cranial nerve 11 is accessory or spinal accessory, so we can call it either by either name. So this is helpful, but you still have to remember, there's 3 O's, O, so you have to remember the order of the O's. So we generally say that there's, the first O is olfactory, so that's smell. So you have one nose, that's why it's first, one nose, and then you have 2 eyes. So both of these are vision cranial nerves. One's optic and one's ocular motor. So just remember, one nose, 2 eyes. And then there's also mnemonics to help students and clinicians remember if the cranial nerve has motor function or sensory function or both. Some cranial nerves only are involved with sensory function. Some of them actually have a motor function, and some again have both. So to do that, to remember that, the mnemonic is: some say marry money, but my brother says big bras matter most. So cranial nerve 1 is sensory, 2 sensory, 3 motor, 4 motor, 5 both. So you can go down. So cranial nerve 10 is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 both. So cranial nerve 10, which is vagus, has both sensory and motor function. Okay, so you can kind of remember it this way by using the different mnemonics. Okay, so let's go through each one of these cranial nerves. Cranial nerve 1 is olfactory. Usually, this isn't routinely tested in primary care. Olfactory emerges from the frontal lobe, so it's kind of smell so you can ask the patient to smell different smells. Occlude each nostril to smell bitter, or cinnamon's a common one, coffee, things like that. So tumors or something that causes head trauma in that frontal lobe can sometimes cause problems with smell. Cranial nerve 2 is optic. This is tested by testing the patient's visual acuity, and also the fundoscopic examination where you're looking, when you're using the ophthalmoscope to look behind the eye and looking at the fundi. So you can put the patient through, you can do a fundoscopic examination, but then also you can do the first part of PERLA, which is inspecting the size and the shape of the pupils and testing the light reaction. So this is because PERLA is actually cranial nerve 2 and 3 together, but cranial nerve 2 does do part of that. So cranial nerve 2 is, has sensory function, and the sensory function is vision. Makes sense, right? Cranial nerve 3 is a ocular motor, so this should tell you that it has motor function. Some say Mary, M means this has motor function. So ocular motor has a motor function, and its job is really to help the muscles of the eye move. So you test this when you are testing for the 6 cardinal views of gaze. If you go back and remember our visual examination when we talked about the eye exam, when you're doing that, big H in the sky and having the patient, you're testing the 6 different cardinal directions of gaze. You are testing partly cranial nerve 3. Altogether, that's cranial nerve 3, 4, and 6. So you can remember that because lateral rectus is cranial nerve 6, superior oblique is cranial nerve 4. All the rest of them are cranial nerve 3. So cranial nerve 3 does most of the extraocular muscle movements, except for lateral rectus and superior oblique, which are LR6, SO4, and all the rest are 3. It's sort of that mnemonic that we use. So cranial nerve 3 is involved with the motor nerve. So with PERLA, it tends to be mostly responsible for the accommodation part, accommodating or changing the shape of the lens so that your lens can accommodate for near and far objects. So cranial nerve 3 is tested by assessing PERLA, and also by assessing the 6 cardinal directions of gaze, particularly only 4 of those directions. But so cranial nerve 3, that's how you test it. Cranial nerve 4, just like we talked about, is tested with the 6 cardinal directions of gaze. So cranial nerve 4 is responsible primarily for superior oblique muscle movements. So remember the mnemonic LR6, lateral rectus, that's the lateral rectus muscle of the eye, is innervated by cranial nerve 6. And superior oblique is innervated by cranial nerve 4. And all the rest of them are 3. So you test cranial nerve 4 by testing the 6 cardinal views of gaze. We're going to skip cranial nerve 5 real quick and skip over to cranial nerve 6, because cranial 6 is similar to cranial nerve 3 and 4. You test it by testing the 6 cardinal directions of gaze. So these abducens, trochlear, and oculomotor are all help the muscles of the eye move and maintain vision, support vision. Okay, going back a little bit to 5. So to assess cranial nerve 5, you'll palpate the masseter muscle as the patient clenches his or her jaw. You're feeling for the strength and the bulk. You can also test sensation of the forehead, the cheek, and the jaw on the side of the face. So this, is trigeminal, so cranial nerve 5. Corneal reflexes, I don't recommend that you test in primary care. Maybe a specialty clinic can do this, but you're not going to. You can, flick the eyelashes and see if it blinks, but you don't want to be dragging stuff across the cornea. Okay. Cranial nerve 7. This is the facial nerve. It assesses for face asymmetry, tics, abnormal movements. You can ask the patient to raise their eyebrows, to frown, to close their eyes tightly, to show their teeth, to smile, to puff out both cheeks, things like that. And all of that will assess cranial nerve 7, the facial nerve. So here is a patient with Bell's palsy, which affects cranial nerve 7 and inability to smile symmetrically. So here is some additional patients. And here's a guy that I like that's smiling, so you can see that he's trying to smile, but this side just isn't moving. So he's got flattening in the nasal labial fold. He doesn't have any of the eye movements as well. Cranial nerve 8 is auditory. This tests hearing. So to test this, you can just assess the patient's hearing. You could do formal auditory testing. Sorry, hold on. Whoa. You can do formal auditory testing. You can test for lateralization and air conduction and bone conduction with the Weber and the Rin test with your tuning fork as well. So all of those test cranial nerve 8 or the auditory cranial nerve. Cranial nerve 9 and 10 are lumped together. So this is kind of easy because you kind of lump these together. So cranial nerve 9 and 10, glossopharyngeal and vagus, are assessed with voice quality. If the patient has a hoarse voice, then they could have a lesion on cranial nerve 9 or 10. You can assess swallowing and dysphagia. So patients who have had strokes a lot of times will have dysphagia. They might have dysphagia because of the muscles that innervate these cranial nerves, but they could also just have dysphagia from generalized muscle weakness of the throat. So it could be either of these. You can also inspect the movement of the palate as the patient says, ah. You watch that soft palate rise. The uvula should be midline. If it's not, then that can be a cranial nerve deficit. You could test gag reflex. Usually this isn't done unless you're testing, getting a strep culture or something anyway. With the uvula examination, the uvula tends to deviate away from cranial nerve 9 lesions. So if the uvula is deviated to the right, it tends to mean that there's a left cranial nerve 9 lesion. So uvula tends to be more innervated by cranial nerve 9. Cranial nerve 11 is accessory, or sometimes called spinal accessory. You can assess this by looking at the shoulders. Usually the shoulders will droop on the side of the lesion. There'll be weakness in turning your head away from the side of the lesion, so you won't be able to turn your head very well. The contraction of the sternocleidomastoid muscle kind of is a little bit weaker. And then there's not a strong shoulder shrug up against your hands when you're applying resistance. Cranial nerve 12 is the last one. This is hypoglossal. You can ask the patient to protrude their tongue and move it side to side. You can press the tongue on the side of their cheek on the inside, and then from the outside you're pressing on their cheek to feel for the bulk of the tongue to make sure that there's a strong muscle there. You're looking for symmetry of the tongue, for atrophy, and that it's midline. With tongues, the tongue, if there's deviation of the tongue, if you have the patient stick their tongue straight out and it's deviated to the right, the tongue will generally deviate towards a cranial nerve 12 lesion. So we call this lick your wounds. So you remember this because your tongue licks your wounds. If it deviates to the right, there's a right-sided cranial nerve 12 lesion. If it deviates to the left, there's a left-sided cranial nerve lesion. Because remember, these cranial nerves come in pairs. There's two of every single one of them. Okay. So here is a quick cranial nerve test, and you have this on Blackboard as well. There's a skills video about this, but you can quickly assess cranial nerves 2 through 12 by doing these these few tests. So how many fingers am I holding up? And you have the patient tell you. That's cranial nerve 2, vision, right? Have the patient look straight ahead and do perla, then follow my finger and do the extraocular movements. Have them clench their jaw as you palpate their jaw. Have them raise their eyebrows, puff out their cheeks, and smile. Have them stick out their tongue, move it side to side. Assess their hearing and their voice quality, and then shrug their shoulders and move their head side to side against resistance, and you're done. So that's a kind of a quick cranial nerve test. And the video on Blackboard shows you can do this in less than 60 seconds. So it's just a general kind of quick cranial nerve test. If you notice problems during these tests, then you'll want to spend more time and kind of look into those particular areas. Okay, so after the cranial nerves, the next section that we're going to talk about is the motor system. So for this you'll want to grossly just assess the body position, the patient's body during rest, during movement, and making sure that there's no involuntary movement, that there's no tremors, tics, fasciculations. If there are, look at their, what's the timing of it, what's the quality, what's the rate, the rhythm, amplitude. This stuff comes with practice. So the more you practice, the better you'll get at doing these. If you see tremors, which are the most common movement disorder, you'll want to look and see where they're located. You can see them anywhere. Sometimes you'll see them in the chin, in the voice, in the head, in the lower extremity. A lot of common ones, the most common one with Parkinson's is going to be that pill rolling in the fingers. And you want to classify them really as either resting tremors or action tremors. So resting tremors occur when the patient's at rest, and the action tremors occur when the patient is in action, doing something, either writing. Some people have a strong tremor when they go to sign their names, so their signature's all over the place. Other people I've seen with these terrible, terrible tremors, but it's only when they have this intention tremor when they're trying to eat. So they grab their spoon, they get a spoonful of food, and then trying to get it to their face, their hand wiggles all over the place and has this massive tremor, and they can't really eat very well. Action tremors tend to occur, again, during the voluntary movement. So these include a number of different types of tremors, like postural, intention tremors, task-specific tremors, like signing your name or eating, things like that. Essential tremors are just these progressive tremors, usually of the upper extremity. They are not seen at rest. They're usually seen with action, and there's no real reason for them. Sometimes there's a familial history, though, where we've seen, oh, my parents had this, or my mom had this, or my grandma had this, things like that. The other thing you should think about in tremors is looking at the medications. There's a lot of medications that can cause tremors, not just the antipsychotics, which are kind of the normal things that we think of, but anti-nausea medications, calcium channel blockers, antidepressants like the serotonin reuptake inhibitors, any other mood stabilizers. A lot of cardiac drugs can cause it as well, and then obviously stimulants, caffeine, all of that. Okay. Your differential is going to be all over the place. Parkinson's disease is the one that people are concerned about. Usually this is a resting tremor. But also think about anxiety. Think about thyroid abnormalities, hyperthyroid states, thyroid toxicosis, where the patient has palpitations, heat intolerance, maybe diaphoresis, potentially weight loss, anxiety. There's a lot more. Alcohol withdrawal definitely can cause tremors. It can actually even cause seizures. It can cause delirium, dehydration, and it typically occurs within a couple days after the patient stops drinking alcohol, but it can happen as long as 10 days after cessation of drinking. So consider all of these different causes. Okay, so when you're looking at the motor system, you want to assess the bulk, the muscle bulk, and you do this by inspecting the major muscle groups and the small muscles of the hands, and you're trying to determine the tone and bulk by putting the patient through passive range of motion, which can look at muscle resistance. You can check for spasticity, rigidity, or flaccid tone. So the flaccid tone is usually muscles are limp and floppy, so they lack any sort of firmness, and this is usually due to loss of activity of the muscles. Whereas the spasticity and the rigidity causes, they're both types of paralysis, right? But the spasticity and rigidity manifest with muscle stiffness and muscle rigidity, and so a lot of times people get spasms, and they're spontaneous, they're uncontrolled, they can be really painful, but this unusual tightness of the muscles. So it's just different forms of muscle and muscle paralysis. When you are grading muscle strength, you grade these 0 to 5. 0 is that there's no muscular contraction detected. 1 is a detectable flicker, but barely there, trace or just barely detectable flicker. 2 is active movement of the body parts with gravity eliminated. So they're able to move that, but you are you're supporting them, so there's no gravity, so you're not doing it against resistance. 3 is active movement against gravity. So this is a person that's laying in bed, can lift up their leg against gravity. 4 is they can lift up their leg with some resistance, and then 5 is they have full movement against full resistance without evidence of fatigue. So this is kind of normal, what we call normal muscle strength is graded 5 out of 5. My population tends to be kind of more 4 out of 5. Unless they have some spasticity or rigidity or a stroke, some sort of paralysis, then they're going to be, 0 or 1 or 2 out of 5, depending. You should test all the muscle strength in all the major muscle groups, and so I've added them here for you to review. And I've also added the innervation, the nerve innervation of this muscle group, so that you know which nerve innervates the muscle group. So if you see weakness, if there's weakness to the hip, if a patient has a hip weakness, then it could be, if they have pain, if they have trouble extending their hip, then you could consider an S1 or gluteus maximus problem. So I had a patient not too long ago with, all of a sudden he had terrible, he was progressing through rehab, he was doing well, he was ambulating again, I think he had had hip surgery. So he's ambulating again, he was doing well, then all of a sudden he was having a lot of hip weakness. I can't remember exactly. I think he had some hip flexion issues, or one of them hip abduction. So anyway, he had some significant hip weakness where he couldn't even lift his leg off the bed anymore. He was having to drag it with his hand to get his foot off the bed. So after a while we ended up getting an MRI, and sure enough he had a lesion on his lumbar spine. So it just showed that the lesions on the spine can cause some of the muscle problems at the site of where they're innervated. So keep this chart handy. You can Google them. You can look at them, the muscle intervention per muscle group. That way you can review when you need. But it's not worth kind of memorizing. Certain ones you tend to kind of memorize. So most people remember that plantar flexion is S1. What's another really common one? Hand grips is always C7, C8 generally. So you'll remember some of the really common ones, but whoops. So rapid alternating movements, this is a coordination test. So this test looks at muscle coordination and your spatial, visual spatial coordination. So you can have the patient do a couple different tests, one of these. So one of them is patting the thigh with the hand and then lifting and pronating the hand and striking the back of the hand on the thigh at the same location. So you're really just patting, flipping and turning and patting with the back of your hand, and patting with the front, patting with the back. And you're doing that quickly, making sure that the patient can do it smoothly, rhythmically, and there's no gaps in coordination or coordination problems. The other thing you can do is have the patient tap their index finger against the distal joint of the thumb and repeat it quickly. They should be coordinated enough to do this. And then finally, the other rapid alternating movement is having the patient tap the ball of their foot against your hand quickly. So here is that rapid alternating movement, the finger against the distal joint of the thumb. So it's not the finger against the distal part of the thumb, but the distal joint, which activates a little bit more of the muscles in the hand when you have to bend to tap the joint here. So they should be able to do that smoothly and rhythmically. You can also test point-to-point movements. This is another really common one that police officers do with neurologic examinations because it involves coordination. So, and part of the cerebellum as well as other areas. But you can have the patient touch your finger, and then their nose, and then your finger again, and then their nose, and you're moving your finger around. So you have them touch your finger, their nose, your finger, their nose, and you're moving your finger. You can test heel to shin, where you have the patient place one heel on the opposite knee and run it down along the shin to their big toe. You wouldn't probably do this to an elderly person with balance issues, but definitely someone who has good balance or someone who's healthy, you would do this to make sure that they have the coordination. And you can do this again with the opposite side, and then you can also repeat it with the eyes closed to test position. Positional is interesting, positional things, which we talked about, I think, with the Romberg test, but position is really a combination of multiple things. So it's not just coordination and cerebellar function, but you're also taking into consideration proprioception and vestibular function and things like that. For ambulation in their gait, the patient should be able to walk across the room. You're looking for posture, balance, swinging of the arms. They should be able to walk heel to toe and then walk on their toes, then on their heels. They should be able to hop in place or do a shallow knee bend. And all of these things can look at proximal leg weakness and position sense and cerebellar function as well. The Romberg test is a test that we do often in geriatrics to assess for coordination, but also balance and the ability to, if the patient, what's the risk of falling and things like that. So you have the patient stand with their feet together, their eyes open. You ask them to close their eyes and keep them closed for 30 to 60 seconds, and you're looking at the patient's ability to maintain their posture without swaying or without minimal swaying. Some people just fall over. You have them do this, and you have to grab them because they're about to fall. So, but they should normally be able to do this without falling. The pronator drift is a test where it's similar to Romberg. You have them stand up, but you have them put their arms out with their palms down for 30 seconds, and you're looking to see that they can maintain this position without their arms starting to drift. And then you can briskly tap downward on their arm, and they should kind of go down, but then kind of bounce back up. So, it should kind of bring their arms right back up. So, and this is on your video as well if you want to see it. Okay, moving on to the sensory examination. Basic principles are to compare side to side. You don't want to just test sensory function on one side without having a baseline. In case you see a deficit, you won't know that there's a deficit unless you have some sort of baseline or control. So the patient can become their own control, and you can test right to left, left to right. When you're assessing for pain, temperature, and touch, you want to compare distal and proximal areas on the extremities, so on the hands and the arms and things like that. And if you see some deficits, you want to try to map out the boundaries of any sensory loss or hypersensitivity to try to see what area particularly is affected and where that extends to. And the patient's eyes should definitely be closed during sensory tests so that they're not getting visual cues and proprioception, all this other stuff to cue kind of what they're looking at. Light touch can be done with a cotton wisp. Pain can be done with a broken cotton swab, applying light pressure from the broken side. Temperature, you don't really have to do this if they have pain sensation intact. Vibratory sense, you can do this with your tuning fork, and you can test it in the fingers and the toes. Proprioception is kind of a spatial awareness, so you can test this by on the distal extremities on the toes by holding the big toe by its sides between your thumb and index finger, pulling it away from the other toes, and then moving it up or down, asking the patient to identify the direction of movement. Obviously their eyes should be closed so they're not seeing how you're moving it, and then they should be able to tell you that if it's moved forward, up, or down. Some of the discriminative sensations, there's 3 of them listed here. I think there's 5 total that your book talks about. But stereognosis is when the patient is able to identify common objects with their eyes closed. So you put it in their hand, they're able to feel and identify an object. That's stereognosis. Graphesthesia, the patient's able to identify a number or a letter that's drawn on their palm with a pen tip. You're not actually drawing it, but you're using the tip of a pen, and they're able to identify what number or letter you drew. That's called graphesthesia. And again, this is done without watching, without looking. And then 2-point discrimination is when you use 2 ends of an open paper clip and you test the smallest distance that 2 discrete sensations can be felt. So you ask the patient, did they feel 1 sensation or 2? And it gets to a point where as you're bringing in the paper clip, they're only going to feel 1 sensation. So the normal distance varies depending on the body part that's being tested. So those are some of the discriminative sensation that you can test. Oh, and then here's point localization and extinction. These are the other two that your book talks about. So there were 5. But point localization is when you touch the patient's skin, you ask the patient to open their eyes and then point to the area that you touched. And often, if they have some deficits, if they've had a stroke, if they have some sensation deficits, sensory deficits, they will get this very wrong. They'll be off by inches or even further. So we can test this in lab and try this on each other. Extinction is when you touch the patient on one side of the body and ask them if they felt it. And then you repeat on the opposite side and ask them if they felt it. And they might feel both of those independently, but then you simultaneously touch both sides and ask them where they felt a sensation, and they'll probably feel it in their dominant side if they've had any sort of strokes or sensory deficits. So they might still be able to feel the sensation when it's an independent sensation, but when there's multiple sensations, then they kind of lose that ability. That's called extinction. Finally, you can evaluate reflexes. So reflexes, I think, are the last part of the neurologic examination that we talk about. So when we talk about reflexes, there's deep reflexes and cutaneous reflexes. We primarily test for deep tendon reflexes, what we call DTRs, but you can also assess for some of the superficial or cutaneous reflexes, like the anal sphincter tone, which we're not going to be testing in class, and then the abdominal reflex with the umbilicus. So we'll talk about those. You grade reflexes 0 to 4. A normal reflex is 2+. So if it's diminished, then it's a 1+. If it's brisker than normal, then it can be 3+ or potentially 4+. You can test all these different deep tendon reflexes, so biceps, and then I've also included the nerve that innervates these different reflexes as well. So this is all in your video. So biceps, the triceps, brachioradialis, patellar reflex, the ankle reflex, and the plantar reflex for Babinski's, where you stroke the lateral aspect of the sole from heel to ball, and you're looking to see that the toes plantar flex. And then here's the cutaneous reflexes. So this abdominal reflex, you can stroke the umbilicus below or above, and you're looking to see that the umbilicus muscles move towards the stimulus where you're stroking the umbilicus. The anal reflex we don't do in class, but you can do it when you're out in clinical practice if you need to, but you use a dull object like a cotton swab, and you stroke outwards in 4 quadrants from the anus, and you're watching for that anal contraction of the anal musculature. And then finally, a couple special techniques. Asterixis. This helps identify encephalopathy in patients whose who has altered mentation. Usually the altered mentation can be from liver disease, uremia, hypercapnia, so it tends to be I tend to see it mostly in kind of liver patients, and then those liver patients that get hepatic encephalopathy. So you ask the patient to stop traffic. So you have them put their hands out in front of them with their hands flexed for 1 to 2 minutes, and you're assessing for the sudden brief flexion of the hands and fingers, where their hands and fingers will kind of suddenly and kind of fall forward. So they're not able to maintain that, stop traffic with their hands sign. So we go over this in lab as well. Brudzinski's and Koenig's signs are two signs for meningeal inflammation. So Brudzinski's, you have the patient flex their neck, and you're watching the hips and the knees while you're doing that. So normally the hips and knees should be relaxed and motionless, but sometimes if they have meningeal inflammation, when you flex the neck, the patient reflexively kind of brings their hips and knees up in order to shorten their meninges, because they don't want those meninges stretched. Koenig's sign is similar. You flex that you're stretching the meninges, so you flex the patient's leg at both the knee and hip, and then you straighten the knee. And then if there's discomfort behind the knee during extension, or if there's significant pain behind the knee during extension, then that can be a sign of meningeal irritation, especially if it's bilateral. And then, let's see, oh yeah, so that's it. So that's the end of the neurologic exam. There is a skills video where we go over the different skills that's available on Blackboard, and then